Let me resume the recording. Okay. First, I'd like to give some guides to this lecture today. Bismillah ar-Rahman ar-Rahim. Let's start. I tried to answer some of the questions that we frequently asked before during our last lectures and any other lecture. Because this is a public lecture, there is no certificate of attendance. This session is video recorded, and this session will be posted in our social media. Kindly follow with us at Twitter and YouTube. And who knows me personally can contact me, of course, and I'll be happy to send him or her the video recording of this lecture. You will notice in this Zoom meeting that you have some small toolbar here showing some yes, no, some tools you can use. Of course, as you know, the most important and annoying part is the audio-visual. So please, if you notice anything, write any comment in the chat box. You can find the chat box, of course, in this Zoom session, or raise your hand. And I'd like to welcome my colleague and my brother, Professor Malk, as a co-host in this session. He will notify me for anything. Because this, again, lecture is public, and I hope all of you will enjoy this lecture. I'm expecting to have audience from different backgrounds. So I prepared the simple poll, if you allow me to share it with you. Just 2 questions. I'll launch it now. Please, everyone who will see this poll, it should appear now at your side. Just comment or choose the appropriate answer for you. The first question is, what is your job title or qualification? Write down, and I'll share the answers with you. I see now we are exceeding 100 and almost 48% voted, 50 plus. The choice is either student, intern, nurse, speech language pathologist, registrar with master degree, or phoniatrician with master degree, consultant phoniatrician, or consultant with any other specialty. You can choose whatever job description. You have still 10 seconds. As you are answering, I'm sure now that my voice is clear, so you got the message. 75% voted. Okay, for the sake of time, I'll stop this vote now. 70% voted, 76, and this is the answers and the results. Almost 1/3 of the attendees are SLPs. They are very welcome, and 20% nurses, 14 interns, students 9%, registrar master degree 11%, and consultants 13%. Welcome all. As you know, I'll try to cover this topic with respect to all the levels. The second and last question or all the specialty. I'd like to know which specialty you are. So kindly, again, 20 seconds. So we can vote. Voted 50% till now, 60%, 60 plus, 65. If we reach 75, I'll stop the poll for the sake of time again. 68%, 69%, 70. 71. Okay, I think this is fine. I'll share it with you. MashaAllah, most of the attendees, almost 2/3 are in our specialty, either phoniatrics and communication and swallowing disorders. 4% our colleague in ENT, they are very welcome. I expected to have anyone from the neurology, but none of them are attending. Nurses, 18%, welcome. Other specialties, 6%, and non-medical, 4%. Okay. I'll go now to start. Bismillah. The theme of this lecture will go like this. I think there is someone is doing some marks here. If you are, please, Dr. Khalid. Okay, the theme will go like this. First, we'll give some introduction, some terminologies, showing some statistics, and historical background about the screening tools of dysphagia. Then we'll go to different screening tools. I selected 7, if I'm not mistaken, 7 screening tools to discuss today or tonight. The third part or third section of this lecture will be to answer your chat questions. You are very welcome to write your questions in the chat box from now, and I'll answer all of them at that time in the third section, inshallah. Then at the last section, we'll have a simple quiz. I prepared simple quiz, not major long quiz, only one question quiz, multiple choice. And we'll have 3 winners. The top 3 who will answer the questions will be lucky to have resources that I used in this presentation, some articles I used to prepare for this presentation, and even more a copy of this presentation they will have, inshallah. So keep tuned with us, and we'll start now with the introduction. Stroke can affect the ability to swallow when muscles involved in chewing, swallowing, or breathing are affected, as you all know. If the alertness and attention of the patient is affected also, this will affect swallowing. And if the independence of eating has been affected, you know, all of us are independent, means that we are eating independent of others. If the patient became dependent on caregiver or some relative or any caregiver, so this means that he has or she has some sort of swallowing problem. As they say always, number never lies. 50% of stroke survivors have some sort of dysphagia, and those population have 3 times greater risk for pneumonia than healthy people, and they have 11 times greater risk of pneumonia with aspiration. This is a very important question. Let me erase this. Sorry, scratches here. So we can, yeah. This is a very important question, the differentiation or comparison between the screening tests and diagnostic tests. I know most of you know the difference, but I meant to put it here to elaborate it more. We need to know what is the difference between screening tests and diagnostic tests. Screening test, from the purpose, is aimed to detect any potential disease indicators. So I'm screening some population to detect whether they have any indicator that may show disease or not. While the diagnostic tests, I'm using it to establish the presence or absence, whether this disease is present or absence, diagnose and not to the presence or absence. So the targeted population in the screening are a large number of asymptomatic people, but still they are potentially at risk of developing any complications. They are asymptomatic for my specialty, but they may have some complications later on from hidden symptoms. But in the diagnostic tests, we are doing the diagnostic tests for symptomatic individuals to establish diagnosis, or those groups who are symptomatic when they became positive after screening. I have to do some diagnostic tests. We have to put in consideration that the screening test to be simple, acceptable to all patients and staff, both the receiver and recipient and the performer, I mean, because we are going to conduct it to large number of people. While the diagnostic test could be invasive and could be even expensive if we are going to use advanced technologies to diagnose some disease. For the positive result threshold, it is generally chosen toward high sensitivity, not to miss potential disease. And we'll talk in few minutes about the sensitivity of the screening test. While in the diagnostic test, they are chosen towards high specificity, I mean true negative, more weight given to accuracy and precision than to patients' acceptability. The positive results essentially indicate suspicious of disease that warrants confirmation. So the screening tells me that there is suspicion. I have to be cautious about this. I need to confirm whether this suspicion is a real disease, a real disorder or not. While in the diagnostic test, the result provides a definite diagnosis. For the cost, because it is simple and acceptable by all, we need to choose a cheap one, and the benefits should justify the cost since large number of people will need to be screened. While in the diagnostic test, higher cost associated with the diagnostic test may be justified to establish diagnosis. We may use any high cost instruments because we are doing this diagnostic test for only those symptomatic patients or the asymptomatic who were positive in the screening test. I hope this comparison between the screening tests and diagnostic tests is clear for you. Our dilemma is that swallowing involves a distributed neural control and neural network. We cannot use lesion localization to predict who will have dysphagia, and who is working in the field of dysphagia knows well this point, because we may face a lot of patients with the same lesion, with the same site of lesion, but not all of these patients have the same dysphagia or the same type of dysphagia, I mean, either the same severity or the same complaint. We cannot determine the risk of dysphagia by patient complaints. That's why we cannot depend only on the complaint of the patient to decide or diagnose dysphagia. The screening tests has two assumptions. Those two assumptions are the previously undetected problems will become major ones if untreated, and treatment exists and is effective. So when they thought about the science, when they are thinking about any screening tool, they have those two assumptions on their mind. I am having a problem that may become complication, or I have this problem that may have some intervention. Why not to screen the patient to detect it early, to intervene properly with those patients? Early intervention through dysphagia will alter the outcomes, and a lot of literature talked about this issue. Martino in 2000 found that 80% relative risk, there is 80% relative risk reduction of developing pneumonia due to dysphagia screening. And another study showed that pneumonia rates are 2.4% at sites who are using dysphagia screening tool when compared to 5.4 at site with no dysphagia screening. This put emphasis on the importance of screening. Okay, why we are screening? The first thing that comes to our mind is I need to know whether there is dysphagia or not. So the first thing, the likelihood of dysphagia. I need to know whether this patient may have dysphagia or not. So after that, I need to do further swallowing assessment or not. So I need to screen the patient to know the likelihood of dysphagia. And in order to know if they have a likelihood of dysphagia, I need further assessment or not. Then comes the last rationale, which is safe to feed the patient orally. I'm doing 1 and 2 with the aim of safe feeding, oral feeding of the patient. This is the rationale simply. What comprises screening tests? What are the steps? ASHA in 2004 put some steps, very simple steps. First, interview or questionnaire with the patients, with the caregivers, with the relatives, either taking short history, distributing some questionnaires to answer. After that, we have to observe some signs and symptoms of oropharyngeal swallowing dysfunction, whether they are present or not. After that, we have to write and document our recommendations, including the need for full swallowing function assessment or not. And then, and we are sometimes forgetting this part, communication of the results and recommendations to the team responsible for the individual's care, and even to the patient if he is alert, and to his or her relatives. So simply interview, observation of the signs and symptoms, recommendations, and communication with the team, treating team or managing team, and the relatives of the patients. The American Stroke Association and the American Heart Association put the guidelines that swallowing should be screened prior to oral intake, while the Veteran Heart Association guidelines is to screen swallowing in all individuals admitted with stroke symptoms. The UK's National Institute for Clinical Excellence mandate screening of swallowing within 4 hours of admission for acute stroke patients. Can you see the importance of screening the stroke patients for dysphagia? But unfortunately, this is the bad news. There is no consensus up till now on screening tool. None of these screening tools that we are going to discuss is gold standard up till this moment. Why? Because they are constructing and implementing screening tool without validation, as you'll see later. Most of the screening tool is not well validated, and some authors and researchers are adopting some published screening tools without close review or doing proper systematic review for those screening tools. This non-consensus on the screening tools caused removal of the screening tools from the Joint Commission's stroke guidelines in 2010, unfortunately. But removal from the Joint Commission doesn't mean that we are stopping screening. Up till now, we are doing screening. It doesn't mean that screening is not important, but because of this non-consensus, maybe when we reach to the moment that we have consensus on the screening tools, it will be returned back again to the Joint Commission's stroke guidelines. Okay, there is some general consideration we have to know about any screening tool. Either we are developing screening tool, or we are studying screening tool and putting them in our mind. Suppose that you have an article talking about screening tool. How can I criticize this article? Suppose that I need to develop screening tool. Those are the most important considerations that you have to put in mind while thinking about developing screening tool, or if you are going to criticize screening tool. Number one, the validation, and the most important one, the validation. The validation means to compare your screening tool against gold standard instrumental evaluation. Here, the gold standard instrumental evaluation, we mean either video fluoroscopy, which is previously known, the 5-barium swallow in some areas, or the fiber optic endoscopic evaluation of swallowing, the FEES. So if I want to validate this tool, I need to compare it with a gold standard tool to check for what's called sensitivity and specificity. Okay. The second thing to put in mind, the time period between the screening and the gold standard. Put in mind when you are reading this article about the screening tool, or if you are going to develop a screening tool, comparing your screening tool with a gold standard instrumental evaluation, don't put a large time period between your screening and your instrumental evaluation, to avoid the effect of the spontaneous recovery or improvement or changing or alteration of the condition of the patient. Most of the articles that used, and there are very few which use this validation, they did the screening and at the same day or even within few hours, and some of them less than an hour, they did the instrumental evaluation. And some of them started with the instrumental, then the screening, to be sure that there is no effect of time. Third, the blinding, because if I'm going to make or to develop a screening tool, maybe I'll be a little bit biased about my screening tool. So the screening tool, when examined against the gold standard instrumental evaluation, it should be blindly, and who are conducting a lot of research knows well what's meant by blindly. It means that I need to do the screening and the instrumental, and the examiners of those, or the commenters, or who are doing the comments on the results of the screening and instrumental, do not know that which patients or which these results are related to which patient. It should be blindly conducted. The reliability, and there is a lot of statistical tests are conducted for reliability, either test, retest, or something like this, to test the reliability of the tool that you are going to use. And lastly, the feasibility. Feasibility means that how feasible, how doable, is it easy? Will it be conducted by nurses and will be easy and every nurse can do it with simple training? Should it be conducted by MDs? Could it be conducted by SLPs? Who will conduct? Will it take a long time to conduct this screening? Is it a simple rapid screening tool taking very short or brief time? So this is the feasibility. So validation, time period, blinding, reliability, and feasibility. We'll stop at the validation to discuss some important terminology that you may face or you may read, and they are a little bit tricky and confusing to some of us. And they reflect the validity, and some authors call it accuracy of the screening tools, which is called sensitivity. Sensitivity by definition is the probability that a diagnostic sign will be present given that the disease is truly present. So here we are talking about the true positive. So how many of those patients are positive when I'm conducting this screening tool and it shows positive results, okay? So suppose that I'm conducting this screening tool and the diagnostic sign is absent, but the disease is present. The disease is present means that there is a disease, and the sign is absent means that the screening is negative. So it gives me false negative. So false negative means that the diagnostic sign is absent. Suppose that this screening tool is giving me whether this patient is aspirating or not. So after screening, I'm telling that it's not aspirating. The patient is not aspirating, but the patient in reality has aspirated. So this is false negative. So high sensitivity equals fewer cases are missed. High sensitivity helps us to rule out the diagnosis, especially if they are negative. Okay, I hope this sensitivity is clear, because when we go now to the other terminologies, which is a little bit also confusing, the specificity. The specificity on the reverse are measuring the true negative, the probability that a diagnostic sign will be absent given that the disease is truly absent. So when I'm saying this, there is no aspiration, in reality, there is no aspiration. So high specificity means that there is good negative exclusion of the patients. Again, the diagnostic sign, if it is present, but the disease is absent, this is the reverse of this one. The diagnostic sign is present, but the disease is absent, it will give me what's called false positive. So this screening is telling me that the patient has aspiration, but on reality, there is no aspiration. We call it false positive. So high specificity equals few false positive. And the test has high specificity, so it has very few false positive. And high specificity also helps to rule in the diagnosis if the patients are positive in the screen. I know this is a little bit confusing, but with time and with much reading, you can understand it well. The other more confusing terminologies are what's called positive predictive value and negative predictive value. The positive predictive value is the probability that a patient with a positive test result actually has the disease, and the negative predictive value is the probability that a person with a negative test is truly free of a disease. I'll give you one example. If you have a screening tool telling you that it has a positive predictive value of 15%, what does this mean? This means that if this screening tool is positive, so there is a possibility or probability 15% that the patient have or has the breakdown or the dysphagia, for example. Okay? How are we screening? Regarding the bolus administration, any bolus, are we administering any bolus or some boluses? What about the amount? Small amount, large amount, moderate amount? What about the viscosity? Are we using thin, thick, puree, soft? What consistencies that we are using? Okay, if it is a questionnaire, what items are important? If I'm giving questionnaire or some questions to the patients or to the caregivers to answer me to come to a conclusion. What items are important from this questionnaire? Why I'm putting this questionnaire? Who will complete this questionnaire? Is this the patient by himself or herself, the patient relative, the nurses? Is it easy conducted or not? What constitutes a failure? When I can say this questionnaire means that the patient failed at this screening. Is there a cut-off point or scoring system? Okay, what happens if there is failure? And what happens if there is positive? Okay, another screening controversy. Who should do the screening? Are there the nurses? And they are with us tonight in this lecture. Are they only nurses? Are they the SLPs, the speech language pathologists, are conducting the screening tools, the MDs? We will answer all of these questions. What type of screening tool should be used? As you'll see in the coming screening tools, some of them are using non-swallowing behaviors, only non-swallowing behaviors, without giving the patients anything to swallow. Some others are using some swallowing behavior, like the water screening or something like this. Or both. Some other screening tools are using either non-swallowing or swallow. These questions we should know about all the screening tools. Okay, this is the algorithm that is mostly and commonly used worldwide for any stroke patients. They should be kept MPO, nothing per os, nothing per mouth. Then the screening, up to the screening of dysphagia. The screening of dysphagia will give me two choices, not three, either positive or negative. Okay, negative means the patient passed the screening, nothing to worry about. If it is negative, okay, we can put the patient to be fed orally and to be monitored by the patient's team member. So what if the screening of dysphagia became positive? Positive means it gives me some signs that suspicious that maybe something wrong is going on. Okay, we have to include here and to involve two persons, the speech language pathologist for bedside proper and full bedside swallowing assessment, and registered dietitian to do the assessment of nutrition to ensure sufficient daily nutritional intake for the patient. The SLP who conduct the bedside swallowing assessment will conclude either the patient as at low risk or high risk. If the patient at low risk, he will be dealt like as he is or she is negative, will be monitored by the patient, will be fed normally and be monitored by the team. But what if the patient is at high risk after the bedside swallowing assessment? We see now we need to be monitored by the swallowing team, either for further assessment, for instrumental assessment, if the patient is candidate for instrumental assessment, or other alternative route of alimentation or feeding. Numerous screening tools were developed from 1997 up to 2015. And as we mentioned, no tool of them has achieved consensus as a standard screening tool. Of course, tonight we cannot go through all those screening tools, a lot of screening tools, but we chose the most important and most commonly used screening tools worldwide. Now we are in section number 2, different screening tools. Okay, we'll start with the first one. The first screening tool is called Toronto Bedside Swallowing Screening Test, or TOR-BSSTO. It was developed in 2009 by Martino et al. It is simple and brief screening tool for dysphagia following stroke. It has two main components, oral peripheral examination and a water swallowing test. If fail any single item, either the examination or the test, screening stopped and the patient to be MBO until swallowing team evaluation. If pass entire test, so the patient mostly will be safe and could be on oral intake, and oral intake could be initiated. It has 91%, almost 91% sensitivity, and you know now what is meant by sensitivity, but a little bit low specificity, 66% or 67%. In the acute patients, the negative predictive value, 93%, while in the rehab patient, it dropped to 79%. What is good for the TOR-BSSTO is it has high sensitivity. It is designed for nurses, so it is easy to be conducted by nurses anywhere in the wards, in the ER, anywhere. The items based on literature review, they reviewed well the literature and put those items, either the peripheral examination and the swallowing screening. But still it has some low specificity, and the majority, if you read the article of developing the TOR-BSSTO, the majority of the study group from rehabilitation, not acute stroke. So this is a little bit some weakness in this TOR-BSSTO, that it is dealt with rehabilitation, not acute stroke, mainly chronic stroke patients. Okay, the next one is the 3-ounce water swallowing test, or 90 ml water screening test, or water swallowing test. It was developed in 2009 by Sud et al. And it meant for screening for all patients regarding the diagnosis, whether it is stroke or non-stroke. The screener here is the SLP, the speech language pathologist, and it is single swallowing item. The simple swallowing item is 90 ml of water to swallow without interruption. We are giving a patient 90 ml of water to swallow directly without interruption. If one of those happens, it means failure. The patient didn't pass. What are these signs? Coughing, choking, up to 1 minute after completion. If the patient is not coughing immediately, even after up to 1 minute, it will be sign of failure. If the patient will develop or will have wet hoarseness or wet voice after swallowing, and the patient is unable to complete without interruption, the patient took some sips and put it down, some sips and put it down because he or she is unable to continue without interruption, this is considered failure. It has high sensitivity, 97%. It is a rapid test, very rapid test, single item, only one single item. There is no delay in completion, it could be done easily, but it has, as you see, very low specificity. What about aspiration? We are giving the patient 90 ml of water. So most of you, I know, thought about now, what if the patient has aspiration? We'll put the patient at risk of aspiration, and you are true. And that's why there is no morbidity studies conducted after developing the screening test. No studies conducted regarding testing or following the patients after the water screening test, whether they developed any morbidity or not. The next one is the Gugging swallowing screening, or it's famously called GUSS. This is a screening tool for acute stroke, and it was developed, by the way, in Marie Gugging in Vienna, Austria. It was conducted either by nurses or SLPs. By the way, it was developed at 2007. And it has something new here, indirect and direct items. Indirect and direct items, and we'll know now what's meant by indirect and direct items. But the most important thing, do not proceed to swallowing items if non-swallowing items are abnormal. Again, do not proceed to swallowing items, which are the directs. If non-swallowing items, the indirect, are abnormal. Okay, what are the indirect swallowing? First, vigilance. The patient should stay alert for minimum 15 minutes. I have to stay with the patients for 15 minutes to be sure that the patient is alert for continuous 15 minutes. Number one. Number two, I have to ask the patient to have to produce cough, volitional cough, or throat clearing twice. Then saliva swallow. I'm asking the patient to swallow his or her saliva and to check the laryngeal elevation and if there is drooling or any voice changes. And the patient must achieve the maximum score to proceed. Again, 3 things to be indirectly. The patient should be alert for 15 minutes, producing coughing twice, saliva swallow, and to monitor the laryngeal elevation, drooling, and no voice change. This is the indirect swallow. Till now, we didn't give the patient anything. If the patient fails in any item of this, to stop this screening and consult the swallowing team. So if the patient achieved the maximum score, okay, we can proceed to the direct swallowing. Here we are giving direct swallowing, I mean some consistencies to be swallowed. And interestingly and surprisingly, they are starting with the semi-solids and the thickened liquids. I don't know why. They start with ½ teaspoon. If there is no symptoms, they upgrade to 3 to 5 teaspoons of semi-solids. If fail, we have to stop. If passed, we can continue to the liquids, water, upgrading volumes, again, 3, 5, 10, 20, up to 50 ml as fast as possible. If the patient fails, to stop. If passed, we can go for solids, bread, 6 individual small pieces. The maximum score of 20. If the GUSS score below 15, this indicates there is a risk of aspiration. This is for the direct swallowing, not the total test. I mean for the direct swallowing. When to stop? If there is delayed swallowing, more than 2 seconds for liquids and 10 seconds for solids. If I notice coughing, drooling, voice change, I have to stop immediately, okay? After that, of course, you'll find high sensitivity. It's very high sensitive, 100%, can you imagine? High 100% sensitive screening tool. And it has high reliability for SLPs who conducted or developed this tool, 95%. It focused on acute stroke. However, still, it has low specificity. Again, the outcomes is aspiration, so there is no morbidity styles. The sample size that they use to develop is only 49, and this is considered very small sample size for any tool to be developed. And the feasibility that we talked about, you remember the feasibility. Consistencies, I need to prepare a lot of consistencies to stay with the patient 15 minutes. It's time consuming. Will the nurses be able or trained well to conduct this, or I should do it by myself? A lot of questions. Okay, the following one screening tool is the Acute Stroke Dysphagia Screening Tool, ASDS. It was developed 2010, and it was developed for stroke patient, acute stroke patients, and it's conducted by nurses, as you can see. Again, it has non-swallowing and swallowing items, or we call it indirect and direct. And don't forget not to proceed to swallowing items if non-swallowing items are abnormal. What are the non-swallowing? It's different than the GUSS. Here, the non-swallowing GCS, Galaxy Coma Scale, shouldn't be less than 13. Any one of them, of these points, if they are present, we have to stop and consult the swallowing team. What are these points? If the GCS below 13, stop. If you notice facial asymmetry or weakness, tongue asymmetry or weakness, palatal asymmetry or weakness, stop and consult the swallowing team. Who will stop? The nurse, because the nurse is conducting this. She can easily monitor the patient to check whether he or she has this facial asymmetry, and of course they know well the scoring system of the GCS. So what will happen if the patient passed this? We will go to the second part with the swallowing. The swallowing here, the 3-ounce water screen. I'm giving the patient the 90 ml of water without interruption. Remember the 3-ounce water screening test. So if the patient passed the non-swallowing, we will go for the swallowing with 3-ounce water screening test. If I notice throat clearing, coughing, or voice change, this means that the patient failed this screening test, and we have to stop and consult again the swallowing team. It has high sensitivity, the acute screening, acute stroke dysphagia screening, 95%. They are focusing on acute stroke, nursing administered, a little bit easy and easily to be trained, the nurses to conduct it. Brief examination, short training period. Short training, the nurses could conduct it easily, just spotting the facial asymmetry, palatal asymmetry, and the GCS score, then to go for the 90 ml to see whether there is any coughing. Very easy and simple, actually. But still, it has low specificity. And they didn't use gold standard instrumental tool, rather than they referred it to a standard, what we are calling Mann assessment screening. We are going to talk about it now, the swallowing assessment tool. They didn't use gold standard tool for validation. ED physician dysphagia screening, this is another tool. I hope my pace is fine for you and you are catching with me. This ED dysphagia, physician dysphagia screening tool developed on 2009. And it was developed for acute stroke patients, again, specifically for acute stroke patients. From its name, ED stands for emergency department, So who will conduct it? The MDs in the emergency department. And it's meant to solve some solutions, some problems that they are facing in the emergency when they are facing a lot of patients with acute stroke. And there is difficulty and shortage of the personnel who are specified or qualified in swallowing. So the MDs in the ED can conduct this dysphagia screening. And again, this is the third one that is having non-swallowing and swallowing items. Again, for reminding you not to proceed to swallowing items if non-swallowing items are abnormal. What are the non-swallowing here? If the patient have complaint of dysphagia, abnormal voice quality, facial asymmetry, expressive or receptive dysphasia or aphasia, some people are calling it aphasia or aphasia. If any of them are present, stop, don't proceed. This means that the patient failed in the non-swallowing. If none of them are present, we can go for the second part, the swallowing. But here the swallowing, you see, it is 10 ml water screening, not 3 ounce like the acute stroke dysphagia, like the previous. If I notice any cough, any voice changes, any drop in the oxygen saturation within 2 minutes, if the drop more than 2%, any of these items are present, it means that the patient failed the swallowing screening and they need to be MBO till swallowing team will be asked for their help. This screening has high sensitivity, 96, high reliability, 97, tested in the ED, which is a very suitable place. If the patient will develop any complication, they will be easily managed, actually. But still it has low specificity, 56%. They didn't validate it with instrumental. There is non-instrumental reference. Actually, the drop in oxygen saturation more than 2%, a little bit, I put some questions about this. This may put the patient at risk, or if I'll wait till the patient will have drop in oxygen saturation 2%, this is a large number actually. It needs some training for MDs. And again, the sample size was 84. This is the next screening tool, modified Mann assessment of swallowing ability. They call it MMASA, developed in 2010. It's developed for acute stroke patients. It's conducted by physicians. Only non-swallowing items. You notice? Non-swallowing items. There is no swallowing items in this tool. Okay, you notice here, this is modified Mann assessment. So what about the Mann assessment? This is the original Mann assessment. It was developed in 2002. What is the difference? The original one had 24 items, as you can see here. I know it is difficult to read, but I just put it to show you that it has very large sheet, 24 items, each item taking score 2, 5, 8, 10, like this, with a total score there. And then to calculate this total score, and they put cut-off points. The modified version, they only choose 12 items instead of those 24. So this is the modified. They chose 12 items. These are the items. And again, this screening tool is only non-swallowing. So I am judging on the alertness, cooperation, respiration, etc. without giving the patient anything to swallow. And I'm putting my score. The maximum score is 100. If the score below 94, this indicates the need for swallowing team assessment and the patient to be put MPO. It has a little bit high sensitivity, 92, high specificity, 86, good reliability, completed by MDs, but not compared against an instrumental examination. It's not compared against it. Rather, it is compared to the original Mann assessment, not to gold standard instrumental assessment. There is overlap in items on screening. If you notice here in the items, tongue movement, tongue strength. So if one of them is weak, it will affect the other, or vice versa. So there is some overlap on the item screening. Training of MDs, they need proper training, and it was not mentioned or specified in their article whether they are trained, how they were trained, and time to administer. I think it is a lengthy screening tool. It takes a lot of time. This is the last one, the volume-viscosity swallow test. It was developed in 2008. Screening for all patients, regardless of diagnosis, not meant only for acute, for all types of dysphagia. The screener here are the SLPs, trained general practitioner or the nurses, anyone can do it. The swallowing items are giving swallowing items. There is no non-swallowing items, only swallowing items. And the swallowing items, notice that it is in this arrangement: nectar, liquids, then pudding. Nectar, liquids, then pudding. And they put something not commonly used before. They called it impaired safety and impaired efficacy. They put some signs. If you will find these signs, it means that this patient has impaired safety. If you will notice cough, again following the oxygen saturation, but this time more than 3%, and voice changes, this means that the patient has impaired safety. And if you notice that there is piecemeal deglutition or oropharyngeal residues after the patient swallows, you can ask the patient to open his or her mouth and see whether there is any residues in his or her mouth or oropharynx. This says that the patient has impaired efficacy. Actually, it was found to be highly sensitive for penetration, 84, and 100% sensitivity for aspiration. And the most importantly, it was validated with VEGF fluoroscopy. So this is one of the reliable, if we can say, tools that we can use, that it is because it was examined against VEGF fluoroscopy. Weaknesses, it has very low specificity, you see, 29% specificity. The outcome is aspiration again, and they are using only swallowing items, reminding you that they are using only swallowing items. Small sample size, and when I read the article, surprisingly, I found that the sample size is 85, 40 of them, almost 50% of the sample size were elderly, where there is a lot of, dysphagia among this population. So by default, most of them will have some sort of dysphagia. And again, there was no morbidity studies for this volume viscosity swallow test. Sorry, I forgot to tell you that it was developed by Cleve et al. In 2008. So this is a table. I try to collect all the screening tools that we discussed now, 7 screening tools, when they were developed between 2007 and 2010, the ones that I used. Again, reminding you, these are not only all the screening tools. These are the mostly commonly used screening tools. Who will conduct? Nurses or SLPs or both or MDs. What are the items I mean here in the comparison? Non-swallow, swallow, swallow only, both non-swallow, non-swallow, swallow, non-swallow, swallow. The sensitivity, you can see it is varying here, but none of them is less than 91, if I'm not mistaken. Most of them has high sensitivity, but the specificity is low for most of them. The feasibility, I mean by the feasibility again, how easy it is conducted. The more asterisks are, the more feasible. The sample size, not acute stroke. It was heterogeneous, both acute and non-acute. Small sample size. This one is large sample size, so it's good. The acute stroke, dysphagia. Small, 150, small. The reliability, can you see the reliability here? Not tested, not tested. It's tested, but only with 2 SLPs, but no, not against gold standard tool. Again, reliable, but with no instrumental comparison. Reliable with video fluoroscopy. So this is again the volume viscosity screening. These are 2 important systematic review articles I found. One of them published in Journal of Advanced Nursing, and by the way, it has impact factor of 2.8. Systematic review published on 2008. Bedside screening test versus video fluoroscopy and fees to detect dysphagia in patient with neurological disorders. And another article, interesting article in a Thai medical journal. This is Thai from Thailand, published in 2016. Again, systematic review. Those are the only systematic review sorry, articles that studied all the screening tools that were developed. Let us see what the results. The first one reviewed 407 articles talking about screening tool from 1997 up to 2007, almost 10 years. And they found, can you imagine? They found only 11 articles used proper methodological tests and proper methodology in their conduction of the screening. While the second one reviewed 104 articles from 92 to 2015, and they found only 8 articles, they call it valid methodological tests. The conclusion, this article concluded that a water test combined with pulse oximetry using coughing, choking, and voice alteration as endpoints is currently the best method to screen patients. So this is their conclusion. What about the second one? They concluded that SSA, standardized swallowing assessment. This was developed by Perry in 2001. I didn't put it in the screening tool. Very simple, one of the first tools to be developed, conducted by nurses, have some checklist and swallowing screening. Again, water swallowing screening, I mean. They found it with favorable psychometric properties, and it is suitable to screening tool for detecting dysphagia. So where are we now? We are about to finish. Don't worry, we are about to finish. Where are we now? We have to come to consensus that screening is very critical and important in stroke patients. Many screening tools are available, but there is no consensus. Most with only high sensitivity. So this is the question. Are high sensitivity and high specificity unrealistic? Is it difficult to develop screening tool to be highly sensitive and highly specific, to depend on it instead of these tons of screening tools? This is the question. What to do? What is our work to do now? We have to administer the water swallow trials if feasible, because you noted both the systematic review focused on the water screening with some precautions and some signs. Reliability of implementation and interpretation over time. So we need to have more time and more work on facilitating implementation is required. So again, this is the same table again, but you will notice that I put some red fonts here for the thing that I hope, or I think all of you wish that it will be available. If we can take the good thing here, which is nurses, to conduct the tool, to have a tool which have no non-swallowing items only, to avoid putting the patient at risk of developing any aspiration or any morbidities. If we have a tool with 100% sensitivity and high specificity and highly feasible and conduct this against a large number of population, to have large sample size and to compare it with reliable and instrumental tool, I think this would be the gold standard tool that we are waiting. We don't have it till now, by the way, but we are waiting to have this gold standard tool. Hopefully, anyone interested or encouraged or motivated from you to start working on this, but remember the general considerations that I told you about putting in mind when developing the tool about the validity, reliability, the feasibility, and etc. Okay, now we came to answer your questions and evaluation. I'll go to your chat to check whether there is, I believe there is a couple of questions here or more than questions. But till I'll answer the question, I'll kindly need from you to answer my questions. As I'll answer your questions, please give me your feedback. I always need to improve myself. So this QR code, if you are working on your laptop, you can screen it with the camera of your cell phone, and it will send you directly to Google form, and you will find it very simple. 5 questions, very easy. And I'll put the link of this Google form now. This is the link. I put it now in the chat. Whoever cannot screen or scan the QR code, they can, sorry, I have to give this. You can easily press the link and go to the document. Okay. ما فيش صوت. مفيش صوت certificate لا توجد. Could you please send me the webinar recording at? Okay, we'll send it to everyone. Inshallah, it will be available. صوت واضح. ما عنديش صوت. Can you please go check? Stroke patient to be. This is from someone. To be MBO tail swallowing screening if negative signs, to start orally with primary team monitoring, if positive sign to refer speech pathologist, low risk or high risk. And okay, I agree with you, Sheikha. This is, I think this is a conclusion. Yes, conclusion, not a question. In your opinion, what is the best tool to use as a screening? And I'll answer this question after the quiz. Because I'll give you the take-home message for you. I don't know who is putting these scratches here. What does facial asymmetry do with dysphagia? Facial asymmetry means that there is problem in the facial nerve. Facial nerve is the 7th cranial nerve, and it is responsible to control the buccal musculature, the labial muscles. So when I find patients, when I'm asking him to smile and I find like this, so the patient has some facial asymmetry. So the facial nerve is affected. So I'm expecting whenever I'm giving the patient anything to swallow, I'll find drooling from the affected side, maybe pocketing, residues in the oral cavity if the patient had this problem or facial nerve problem. Could you compare these two together in terms of advantage and disadvantage? I think it was before the table, and I put the table, it was clear. I think it is difficult to account on them. However, I used GUSS several times. It was magnificent for some patients, but still we need instrumental assessment. And this is, yes, the controversy. The water screening tool doesn't exclude silent aspiration. No, the water, if you are talking about the 3 ounce, the 90 ml, I remember there was an article by Langmore, if I'm not mistaken, and when she came here 2010, and I discussed this issue with her, and it was clearly stated, and the article proved it, that they chose the 90 ml, especially 90 ml, not haphazard. They chose the 90 ml because they found this volume, even the patient has silent aspiration with very small amount, 3, 5, 10, even 10 ml, they have silent aspiration. The patient with 9 ml will show some signs of aspiration, choking, or some coughing or voice change. And this is this was validated. I don't know. I cannot go to. Why the rest of the question is not clear for me here? How to choose the suitable assessment? I'll answer again. I have to. It's working now. How to choose the? I'll tell you. Water swallowing has false positive. Of course, every one of them has false positive and false negative, because except the one that has 100% sensitivity. Condition, but can exclude silent aspiration, which is in turn will get your patient for instrumental because of high positive, false positive. I couldn't get this. Is this the question or not? Why do you consider water aspiration as a side effect from the screening, while lung could clear small amounts easily? Yes, if the lungs could clear some amounts, 3, 5, or 10, but what about the 90 ml of the water screening, the 3-ounce test? And by the way, not all the lungs can clear the 3, 5, and 10. I know you mean by clear to be absorbed. The water, the liquids could be easily absorbed by most of the people, but not all the people. It depends upon the condition of the lung, the respiratory status, the age of the patient. A lot of factors affect whether the patient is able to expel, and we experienced a lot of patients with aspiration with very small volumes of liquids, and they develop aspiration pneumonia. What about YAL screening test? Yes, I didn't mention it, but it has its also pros and cons. Sorry, this is me answering the question. Okay. YAL. What is the safest consistency for stroke? This was sent to me privately. We cannot say safest consistency for the stroke patients, because this is one of the dilemma that I mentioned in the first some slides. It is a complex network controlling the swallowing muscles. So we cannot generalize that thin liquids are safe for patients, because they could be expelled. The thin liquids could be expelled. But what if they weren't expelled? Our kind colleagues in neurology department, I know most of them are starting using Burey. They are telling us Burey is the safe consistency in all stroke patients. My answer to them, okay, what if the patient has aspiration for Burey? Burey, if the patient will aspirate from Burey, 100% he will develop, or she will develop, aspiration pneumonia, and it will be very difficult to be expelled. So there is nothing called safest consistency for patients. Safest consistency, if you're talking about thin, thick liquid, Burey, and soft mechanical, some patients have thin liquid safe for them, and other stroke also patients have soft mechanical, which are the most safe. Does thermal tactile stimulation electrical stimulation help with stimulating labial muscle? Yes, but this is another issue and another topic for another lecture. If you want, we can talk about it somehow, but properly select the patient to use thermotactile and electrical stimulation. Thermotactile, the disadvantage of thermotactility has very brief effect. If you can imagine, if you are going to give the patient thermotactile, and it was some of my dissertation in the MD, it is only viable for 1 or 2 swallows. After that, you have to make thermal stimulation again. Don't forget that there is winners for the quiz. We still have 1 quiz. Wait, please, for the quiz. The question here, also in a study we conducted, was screening sensitivity was way less than suitably. Proposed the claim about the volume increase will elicit cough was argued because some patient had silent aspiration on fees, but not evert on. This is, I know this is still controversy, but if I have the article, I would share it with you now with Susan Langmore, that she mentioned that the 90 will trigger aspiration even if the patient has silent aspiration. Do you think what is the most, what is it a must to do screening, or we could proceed direct to instrumental? If you are working in the field of swallowing, not all the patients could easily do instrumental. Instrumental needs assessment, and if you attended from the start, there is screening and diagnostic tests, and we compared between both of them. for best utilization at your institute, you cannot do an instrumental for all your patients. You cannot do this. It will be costly, and your time, you don't have the time for, I don't know what is the load of the patient that you have in your center, but better to have screening to filter those patients, and from this filter you can do the test, the instrumental, I mean. Patient in our hospital introduced right tube all stroke patients. So at this point, do screening for dysphagia have a role here, or they should receive an instrumental assess? The screening test doesn't mandate the patient to be not on NG tube. Nothing in the literature was mentioned like this. So even if the patient on NG tube, nasogastric tube feeding, we can do the screening still. And we have here advantage that if he failed, he can continue on the NG tube feed. I think we somewhat lost our trust in screening, and it became the opposite of time and effort saving. Not to lose the trust. By the way, you will see and you will know which screening tool to use, and which not to use, when to use it, and with which patients. Okay, now we came to the last section of our presentation today. We are way of time here. The quiz. I'll give you scenario, simple scenario. You have to read it, and I read it with you. And after that, I'll give you 4 choices to choose between them. Choice A, B, C, and D. And the first 3 to write or to type in the chat box. In the chat box, you have to write in the chat box. The first 3 who will write in the chat box the correct answer will receive the resources that I promised them with. Okay, are you ready to go? Hopefully, okay. A 60-year-old male patient who had massive ischemic left middle cerebral artery stroke 2 months ago. The patient was put on nasogastric tube feeding since admission. The patient had affected level of consciousness, GCS 12. The patient was shifted to regular ward with the same level of consciousness and has difficulty in communication with the surrounding. It was referred to the swallowing team. So what is the favorable screening test to do? Okay, favorable screening test to do. You have to select one of these screening tools and to type it in the chat box. Number A, GUSS, Gugging swallowing screening. Number B, ED, the emergency department physician dysphagia screening. Number C, the 3-ounce water screening. Number D, the acute stroke dysphagia screen. I'll open now the chat box and see. MashaAllah, MashaAllah. Either to write the name of the tool or to write the letter of the correct answer. I'll give you 30 seconds. I'll take my breath and leave you to think about it. Then I'll give you the right answer. Think about it. Okay, I think it's fine. No more. Oh, still some answers coming. For the sake of time, I think I'll go for the correct answer. And the correct answer is number C, the 3-ounce water screening and 3-ounce water screening swallow tests. And the explanation for this, you will notice here that the patient was on NG tube feeding since admission. That was 2 months ago. So most probably this patient will have affected laryngeal sensation. So we cannot go for GUSS because GUSS start with Burette. And as we mentioned, starting with something at high risk of developing aspiration will put the patient at risk. Second, the patient shifted to a regular ward. So no rule here for the ED. The ED, as I told you, it was done and conducted for the purpose of being used at the emergency department in the ER. So the patient admitted 2 months ago and already shifted to the regular ward. So no need to conduct the ED. The GCS, if you noticed, it was 12, and this is against using the acute stroke dysphagia that prevent doing or conducting the GCS if it is below 13. Okay, let me check the answers. The first 3 C's or 3 ounce, this is Ahmed Abdurrahman. Then C, DA. Okay, I reply to every one of them with my email. They can send me their email so I can send them. And first one, who is the first one? I don't want to miss him. Ahmed. This is my email, Ahmed, and you can email me so I can send you. I'll go back again. Finished Ahmed, and the second C finished. Then this is the third C, I think. Nada. Congratulations for the winners. Okay, we'll go for the take-home messages, and this is what I need to tell you at the end. Study the tools well. I need from you kindly after this to study those tools, or all the tools if you want. I mean the screening tools. Adopt the suitable ones, and I meant ones, not one, because not single one is suitable for all the patients. You may have one screening tool suitable for one patient and not suitable for other patients. So you have to put in your mind, you have to have your choices between your hands. So you can select according to the situation, to the institute, who will conduct the screening tool, the time, the medical condition of the patient, where is the patient admitted at. So you have to select from those criteria which tool or which best tool to conduct. So adopt the suitable ones, follow your patients. By following your patients, you can know whether you're doing a great job or something happened mistakenly. Then early intervention and recommendations. Very important to have early intervention for your patients and to put your recommendations in the medical records of the patients to be on a safe side and to protect your patients. If you will follow these messages, be sure that your patients will have safe swab. Thank you very much for attending this lecture. I hope all of you enjoyed. I'll send you